Well, I guess we'll get started. Thank you all for coming. My name is Jeremiah Tao. I know some of you, but for those of you who don't know me, I'm the director of the Oculoplastics Specialty Service, which you probably didn't even realize was a subspecialty, but it's one of the 7 or 9 subspecialties within ophthalmology. We deal with everything outside the eyeball, the eyelid, the orbit, the tear drain, the face adjacent to the eyeballs. And the topic today is going to focus on cancers of the eyelid. And you might not have been aware, some of you might be aware that cancer can occur on these structures and can cause serious problems. I'm glad I didn't feed you anything too big, because I'm going to show you some scary pictures just to start you off and get your attention. These are examples of what can happen with some of these small little skin cancers or eyelid tumors that grow unchecked or that aren't treated on a timely or time-sensitive basis. Some of these patients very commonly have mental health issues or other access problems, but these are things you would think you'd only see in third world countries or places where you don't have access to care. But these are both patients that presented right here in California. Again, many of them have other issues such as mental health problems or other access problems, and usually we don't see this scenario, but sometimes they don't. Sometimes patients are have total access. This is a patient that has a daughter who was a nurse, in fact, and this was a squamous cell cancer that started on the temple, the outside of the eyelid, just eventually eroded, not only through the orbit and eye socket, but actually down to the level of the brain. So potentially really scary, lethal things. There is, at the top of my list, sorry about all these gross pictures, but this is probably the worst type of surgery that I have to do for some patients. We have to just clear out the whole eyelid, orbit, eyeball, everything. In other words, that's the only option in some of these patients who have cancer that's gone uncontrolled that is a life-saving procedure. Fortunately, we're not dealing with that. And today, by the end of this talk, you're going to educate yourselves and all your friends. And anytime you see somebody at that Christmas party or family reunion, you're going to say, you should get that checked out, because you're going to be able to get a handle on what makes an eyelid lesion suspicious or not. And the question I want to pose is really, when should we biopsy? This is a lecture I give to other doctors, other primary care specialists, but I think it's important for anybody who even has an eyelid lesion to just kind of understand, have this basic sort of rubric for deciding whether they should worry about something growing on the eyelid. Obviously, we remove things off the eyelid and face for more reasons besides just a concern for cancer. There are certain tumors of the eyelid that can weight down the eyelid, for example, or cause itching or scratching of the cornea. Sometimes little tumors or cysts along the eyelid can turn eyelashes in and cause some irritation. Very commonly, some of these things are just sort of ugly, and they're kind of growing there, and people don't like the way they look. So we very commonly remove these things just purely for aesthetic or cosmetic reasons. So why do we get cancers on the eyelid? Well, the primary reason is that the eyelid consists of a lot of skin. That's the first layer of the eyelid. The skin is known as the largest organ system in the body. We typically don't think of it as an organ because it's just this outer layer, but it is perhaps the most common source for carcinoma of any sort. There's really 2 anatomic structures that make up the skin. There's the epidermis and the dermis, and this is important to understand the types of tumors that grow on this structure. For the top layer, known as the epidermis, this is where we have the most common type of cancer, probably the most common cancer of all cancers. It's basal cell carcinoma. This is a cancer that arises from the base layer of this top layer of skin, and these are undifferentiated cells that can grow into normal cells, but sometimes the mechanism for normal growth goes haywire. Squamous cell carcinoma is another type of tumor that grows in this top layer. This is fortunately less common. Unfortunately, it is much more aggressive. The skin also has pigment. There are a variety of cells called melanosomes, and you've probably heard of melanoma. Melanoma is sort of the result of some of these pigment cells growing into cancers, as opposed to just growing into normal pigmented colored cells of the skin. The dermis also has other structures within it, living within it. For example, we have hair follicles, as you know, and then there's also oil glands and sweat glands. And all of these structures can be the origin for cancers and other tumors that we don't want. The most common adnexal, so that the term adnexal means these other structures within the skin, not one of the core layers of the skin, dermis or epidermis, but it's sort of the other things we find in the skin, the glands, for example. The most common malignancy we see within the skin is this tumor called sebaceous cell carcinoma. By comparison to basal cell carcinoma and squamous cell carcinoma, sebaceous cell carcinoma is very, very rare, but it's an important one to understand to understand. So skin cancer is the most common cancer, especially in the United States. It's increasing, and no matter what we do, unfortunately, we're seeing more and more of it as time goes by. Some of it is just that we're living longer. One theory is that the skin wasn't built to live this long, and as long as we live longer, we're going to see more of it. There may be some environmental changes. Who knows what's preservatives or pesticides? We don't know exactly. In general, skin cancers, the basic principle is that they're easier to treat when they're small in size. Don't wait till they get to those slides, the first two slides I showed you, where they're all over the place and invading the eyeball, in fact. Another theory of why we're seeing more cancer is that there's this whole era. I think most of these people in the group, except for our two ninth graders here, probably lived through the decades where skin was good for you. How many remember all these tanning salons we used to go see all over the place? They're still around, but it used to be healthy to be out in the sun, and people used to slather on baby oil and just bake out there. And a little bit of a sunburn was understood to be healthy for your whole body. So in general, we're going to sort of break down the question, is a growth suspicious or not? I'm going to show you some examples, and then we're going to just cover some of the basic entities that we find in the skin. I'm going to skip the Merkel cell at the end. You'll see basal cell is by far and away the most common, probably by a 95 to 99 to 1 compared to the others. And then squamous cells probably maybe 5%. And then down in the 1% zone is melanoma and sebaceous carcinoma. Merkel cells probably even less. That's probably like a 0.5 or 0.1%. So I'm going to skip the Merkel cell today. So the question is really, when we deal with anything that is growing along the eyelid or on the face, and just a reminder, anything I'm talking about with this eyelid, with these eyelid tumors, applies for any skin on the body. But anyways, the history does give us some clues. A patient's age and history of sun exposure certainly raises some suspicion for carcinoma. Growth of the lesion or change in the size or shape, configuration, or any other behaviors, especially bleeding, these are not normal characteristics of benign growth. So any of these things you see listed here are clues that you might be dealing with something cancerous. When we look at these lesions, our eyes are probably one of our best tools we use as clinicians to decide whether something is suspicious. And there's no diagnostic visual clue, but these are just as I said, clues. These give us sort of an intuition whether we should worry about something or not. And it has a lot to do with pattern recognition. Basically, this is a pretty good list of the characteristics of something cancerous on the skin. Ulceration, I'll go take a deeper dive in each one of these later, but I'll just list them out here. Ulceration, lack of tenderness. This is sort of surprising to other physicians. A lot of cancers of the skin actually have no pain associated with them. Induration, they can be kind of hard and sort of firm. Irregularity, so the shape and configuration, the thickness is another feature. Telangiectasia, a lot of cancers have fine new blood vessels. That's a fancy word for fine new blood vessels. With basal cell carcinoma, there's something called a pearly texture, and I'll show you some pictures. It does really look a little bit shiny and kind of smooth, like a pearl. And then on the eyelid, we also look for loss of the normal architecture. So the edge of the eyelid has several structures, including eyelashes, that we check out to see if there's anything abnormal about them. So ulceration, this is sort of the general term for a central area that's sort of raw and not healing. Some people call these like craters, or you can think of a little volcano, that the internal area is sort of hot and there's something happening inside there. The general thought is these tumors start to grow, and then they grow so rapidly and haphazardly that they outgrow their own blood supply, so that central core of the tumor kind of dies off. So you have this sort of crusty, red, bleeding central area. And this pattern will kind of repeat. Sometimes patients will say, oh, they think the thing fell off, and then slowly it'll grow back. So it's this behavior of outgrowing its own blood supply. And that is the fundamental problem with any type of cancer, is that these are cells that just grow without any sort of plan. They just grow haphazardly and grow bigger, and they can spread to other organs throughout the body. Thankfully, with basal cell, we don't really have to deal with spread too often. They generally just get bigger where they grow locally. So this is just another example of that central ulceration. You see that sort of crust in the middle of this sort of raised up, heaped up border appearance. So lack of tenderness, like I said, is a somewhat surprising feature for many. You'd think that something cancerous, something so horrible, would possibly cause some pain or discomfort. The tumor itself typically does not have this behavior. There are other reasons patients have discomfort or even pain with these growths, particularly due to the surface of the eye. The cornea and the surface of the eye is one of the most sensitive parts of the body. So anytime we have something disrupting the normal protection that the eyelids provide to the surface of the eye, we can have dryness, irritation, foreign body sensation. If there's a frank misdirected eyelash, for example, that can also cause some severe symptoms. In duration, malignant tumors tend to be firm as compared to benign cysts or other things. They're sort of squishy and soft. Benign tumors, as a general rule, feel more like their surrounding tissues. So if you palpate or touch them, they seem more aligned with or akin to the tissue next to them. Tumors or malignancies are a little more firm. Irregularity, like we talked about, again, malignant tumors are cells that are growing at a rapid pace, but also at a different pace within the tumor. So you tend to have an area that's not balanced with the other. One general rule is that they aren't particularly round or symmetric, left to right or up and down. And they can also have different levels of elevation and curves and contours, asymmetric shapes. Benign lesions, on the other hand, tend to be smooth, round, or domed. I'll show you some examples. These are some examples of basal cell carcinomas. You can see that they're not perfectly symmetric all the way around. You can't fold them. If you were to take a two-dimensional image of these things, you can't fold it over and it doesn't look like its other half. But they basically have other crust and other sort of things going on. So contrast that. These are called syringomas. These are benign lesions. They're very common. They say in sort of middle age to younger women. These are benign lesions they're very, very common. They're just little round, smooth growths. And you can see that they're relatively symmetric comparatively. This is another benign lesion. This is called an intradermal nevus. You can see how it's just sort of fairly circular and fairly symmetric if you look all the way around. In contrast, this is a basal cell carcinoma. You can see how the border is sort of indescript. You can see its scale and crust and the possible areas where it's raw. You really can't define where this starts and stops, and clearly you can't say that this is a mirror image, top half to bottom half, or left and right. Telangiectasia, this is a fancy term for fine little blood vessels. They're commonly dilated and just sort of irregular and haphazard. Perhaps the most common malignancy of the skin that we see this in is basal cell carcinoma. Just some more examples. Sometimes you need a microscope to see these. If you've ever been to your eye doctor, the slit lamp is sort of a microscope that the doctor uses to look at things close up, and you can see these fine blood vessels. Pearly, this is a good description for a lot of basal cell carcinoma. This is a classic basal cell carcinoma that's sort of mounded, and you can imagine has that shiny, sort of smooth characteristics of a pearl. That combined with the telangiectasia is really sort of pathognomonic, or that's a fancy term for one of the key things that clues us into a basal cell carcinoma. There are different subtypes of basal cell carcinoma. The most common is this nodular. It's a good description because they look like little nodules. Another one right here, you can see how it's sort of raised, round, firm. There is one other entity we see very commonly that tricks us sometimes. This is an amelanotic nevus of the eyelid, and you can see this. It may have some of the same features we just talked about, the little telangiectasia, possibly raised and kind of pearly sheen to it. Here's another one. But the one thing you'll notice about these two is that everything around it is fairly undisturbed. If you look at the lash line, there's really no fallout of the lashes or disruption of the edge of the eyelid. There's no notching or other anatomic structural damage to the eyelid margin. To contrast, for these nodular lesions are cysts. Cysts are fluid or other fluid or other sebaceous material filled sacs. These are commonly sweat glands that just are supposed to drain to the surface but get plugged up, and they just fill up these little balloons. But you can see that these are fairly round, symmetric, and domed, and otherwise not suspicious compared to the ones we saw earlier. And especially if you feel like you can see clear fluid in it. We know this is a benign hydrocystoma. These are typically either sweat glands or tear glands that just, again, get trapped and the fluid just forms into a balloon as opposed to draining constantly. So as I started to mention, it's the margin architecture. So you saw those papillomas that I told you were benign because the lash was totally, the lash line and the edge of the eyelid was totally normal. Contrast with this basal cell carcinoma, where you can see that there's a divot in the eyelid. That is not a normal feature. And the other thing you might notice is the lashes have all fallen out. There are very few benign growths that cause lashes to fall out. Matarosis is the scientific, or sorry, the technical medical term for lashes falling out, but that's a very strong feature or strong indicator that we might be dealing with something malignant. We don't really know exactly what the cause is, other than the tumor cells may be outgrowing or overtaking the follicles. We talked about the way tumors outgrow their own blood supply and die off, so we might have a little bit of sort of cell death. It just sort of kills off the normal tissue there, and as the body heals, you get these little jagged edges and notches in the eyelid. But loss of lid margin architecture can be sort of more subtle. This is what's called a morpheaform basal cell carcinoma. You can just see the edge of the eyelid just doesn't look right. It looks like it's been sort of burned or otherwise traumatized, but this patient really has had no trauma other than just years of sun exposure. Here's another good example of the lashes. It's a little fuzzy, but you can see that the lashes sort of go, and then all of a sudden over in front of where this little elevated area is, they drop out. That is a good clue to the architectural change there. And you don't have to have a notch. The point of this slide is that you can sometimes have an elevation. So any disruption to the normal smooth line there is a clue. The important thing to remember is that not all these characteristics need to be there. Sometimes just recurrence after something's been cut off is enough of a clue that we're dealing with something malignant. And there's really no clinical sign or visual characteristic that tells us 100% one way or the other. There are certain tumors that I would bet money on that are going to be something malignant, but we've been fooled either way. There have been things that we could swear follow all the features that we describe that follow malignancy that turn out to be benign. And quite commonly the reverse. It's we're ever surprised. Sometimes we just biopsy something during other surgery where it's in the way, or a patient just at the last minute before surgery. I had that happen the other day. I had a patient with a left eyelid lesion, and he just said, "Can you take off this freckle here?" And we said, "Well, I guess we can just add that on while you're here. It's so small, it's not going to add too much time, or it's not going to be problematic." And this one, the one we just happened to add on at the last second, turned out to be the melanoma, and the other one turned out to be benign. So there's all these sort of clues that clue us in. Basal cell carcinoma, I'm going to dive into this slightly. This is the most common skin malignancy. This is the one that the dermatologists deal with. Pretty much any dermatologist deals with this on a daily basis. These are 90 to 95% of all eyelid malignancies. And again, UV damage. And there's a tendency to occur in certain racial and sort of ethnic predilections. Fair complexion is sort of the main risk factor, I suppose. The lower eyelid and the inside corner, called the medial canthus, tend to have more tumors than other locations. There's one theory that the lower lid of the medial canthus receive more UV rays. The brow and the hair, the eyelid is sort of shadowed by these other structures, so that the lower lid and the medial canthus are particularly susceptible to UV damage. So basal cell carcinoma is not, the first thing I tell patients when we diagnose is not to be thought of in the same category as liver cancer or pancreatic cancer or lung or breast. These are not tumors that we're typically you're going to do a full body PET scan and worry about metastatic spread. They don't tend to jump into the bloodstream or lymph nodes and travel elsewhere. They tend to just grow locally and get larger where they started. Another term for these tumors is a rodent ulcer. They tend to just grow and eat away at what they're where they started. They can kill. They actually do have some mortality if they get big enough or if they invade vital structures. And when we're dealing with eyelids in the face, the skull base and the brain and are right there. So it's actually not completely out of the question. The serious complications, the morbidity and mortality, tend to be associated with cancers on the inside corner. Again, this is closer to the sinus and the skull base. That's the main reason. Patients who've had prior radiation, these are tumors that are a little harder to control. And then obviously tumors that are very large and neglected, and like the ones we showed you. These are the ones we showed you, same slides as we showed you before. But again, rodent also, you can imagine there's a little rodent or rat kind of eating away. It's a reasonably good description for what the basal cell carcinoma characteristic is. 3 subtypes, again, nodular is the most common, morphiiform is less common. There's a really uncommon type called superficial. Nodular are these sort of raised tumors that sometimes have that central ulcerated core. And again, these are sort of classic nodular tumors, raised, heaped up borders with the central area. This one was sort of an interesting one. They can sometimes have pigment, so they can look like little verruca or warts or other nevus tumors that we'll see. The clue that would make this one more suspicious than just any other freckle or a little bump or age spot is that the lashes are falling out. And you can see a little bit of irregularity and perhaps some of the telangiectasia that we talked about when you look up close. Another nodular carcinoma. You can see areas where it's sort of crusted and kind of trying to heal itself. Again, that's sort of the sign that the tumor is dying off in that area, and then it's just trying to repair itself. In general, the nodular subtype is the most common and the most treatable. Morphiiform is fortunately less common because it's harder to treat. The reason it's harder to treat is because the edges and the borders are harder to define. They just commonly look like little scars or surgical scars or other scars otherwise, trauma, for example. This is a gentleman that has just a little area that just doesn't heal on the inside corner. He thought that maybe he's wearing his glasses too long, and that is a reasonable hypothesis or theory for the patient to have, but when we go to biopsy the area, it turns out to be cancer. This is just sort of not a normal, typical behavior. Another one, just a little raised, kind of crusted area under the brow, turned out to be a morphiiform carcinoma. And these are sort of the more classic morphiiform as opposed to nodular. They're sort of flat and kind of irregular as far as the borders and have sort of different areas of redness and some areas that are crusted, some places are scabbed. These are very difficult to diagnose because these very commonly occur in patients who've had just a lot of sun damage. This looks a lot like just routine run-of-the-mill sun damage. Again, and then where does it start and stop on his lower eyelids? Both lower eyelids look affected, perhaps a little bit worse on the right side because it's turned out more. Just another tricky one. Just looks like a little redness or dermatitis or blepharitis, and just wasn't going away with the normal treatments like steroid drops or antibiotics or heat compresses, and we go on biopsy and we find out we're dealing with a cancer. Another one where it's just contracting. You can see this is a behavior of skin cancers anywhere around the eyelid, even far away on the cheek. If it's contracting or causing enough scar, it's pulling the lower lid down off of the eyelid. There's a condition called ectropion where the eyelid doesn't protect the surface of the eye, and can make the eye very dry and irritated. But just some more examples of this morphiiform that again just looks like chronic sun damage. Superficial basal cell carcinoma is more common, they say, on the extremities, the hands and feet, but it occasionally occurs on the face. This one is even more particularly difficult to diagnose. These just are little red patches that would not otherwise raise suspicion. So the reason in all these cases we diagnose them is that it's just not going away, not behaving properly to the normal sort of treatments. If it's just inflammation, dermatitis, allergies, these things should go away with time, if nothing else, if not steroids or other topical medication. These are just all lesions, little red areas that just persisted in spite of everything we did for it. And that in itself is an indication that a doctor should start thinking about doing a biopsy. Again, this is a really surprising one, just a little red spot underneath the eyebrow that turned out to be cancer. The next most common type of cancer we see on the eyelids is squamous cell carcinoma. It is by a 9.5 to 1 ratio less common than basal cell carcinoma. It is a distant second place cancer. Same risk factors as basal cell carcinoma. These are sun-damaged areas. These are commonly patients who have fair complexion. They say Northern European or Scandinavian descent is sort of the classic sort of region of the world where there's a high density of patients with these issues. The classic feature of squamous cell carcinoma is the keratin. Keratin is that top layer. It's like our fingernails have keratin. It's that little scaly, rough patch on the surface. It has a lot of the similar features of basal cell carcinoma in terms of ulceration. It also can have telangiectasia, those funny blood vessels, and also redness. Fortunately, it's less common because it tends to be more aggressive than basal cell carcinoma. Within squamous cell carcinoma, there are several flavors, or if you will, of ones that behave less aggressively than others. And so anytime we see squamous cell carcinoma, we really look for the pathologist's sub-report where they describe what's happening at the cellular level. And they'll say it's invasive or say show something called high atypia. These are fancy terms that kind of tell us that the tumor is dividing rapidly or behaving badly. Is that a word? Donald Trump uses that word badly. But margins, again, like the morphiiform basal cell carcinoma, are harder to define. That's another reason they're harder to treat. But again, this keratin, that rough, scaly material, is one of the sort of classic features of squamous cell carcinoma. With the naked eye, they very commonly are indistinguishable from basal cell carcinoma. These are examples of squamous cell carcinoma that look very similar to those morphiiform basal cell carcinomas that we showed you. But you can see the little scale, rough patches and crust that are some clues. The other things we talked about earlier, lashes falling out, and the architecture of the eyelid margin kind of turning over and not regular as before. So these tumors are treated with wide resection. We cut out what we see, but then we jump over and try to take some normal tissue to make sure we get every cell out. And the reason we like to treat these aggressively because they tend to spread. These are examples of squamous cell carcinomas that just really just like to go wherever they want. This one, in fact, invaded the orbit in the eye, and the patient had to lose his eyeball and everything around the eye to get rid of this cancer. The one really scary behavior of these tumors or squamous cell carcinomas is it likes to invade sensory nerves. So there's a rare phenomenon where these will travel back in towards one's brainstem. We'll see tumors deeper, and we wonder how they got there. Well, it's really because it follows these nerves and goes inside. They can spread through to lymph nodes through lymphatic spread. Rarely they can jump into a blood vessel and show up somewhere else. That's very unusual. There are sort of no man's land tumors. These are sort of basal squamous cell carcinomas, and in general, we opt to treat these in terms of the more aggressive type. So if we see basal squamous on the pathology report, we would probably consider it a squamous cell carcinoma and do a wide excision. So squamous cell carcinoma, just like that morphiiform, can look like sun damage also. These are often indistinguishable from something called actinic keratosis. Actinic keratosis is one of the most common skin findings. These are just scaly, rough red patches, fairly common in older patients with fair complexion. You've probably seen these on people at the mall or relatives and friends, but they are quite common and very difficult to distinguish from cancer. So in general, we biopsy. The other things that sort of are in the differential that can look like squamous cell carcinoma is something called seborrheic keratosis. These are really, really common benign tumors. They also have the same risk factors: sun damage, old age, fair skin complexion. These have a classic textbook description as greasy and stuck on, and that's sort of a weird description, but if you look at some of these, they have that, they look like they have just a little one area that's kind of holding them onto the skin or the eyelid, and they kind of have this oily yellow, brown, tan appearance. Here's just another example of a sort of a seborrheic keratosis over on the lateral eyelid and cheek. So I mentioned the sebaceous cell carcinoma. It's very rare. It's probably, in some reports, less than even 1% of all eyelid cancers, but it's very important. This is one of the things in all of ophthalmology, all of any eye provider learns about sebaceous cell carcinoma, because it's one of the very few things that kills. This is actually, if you look at all the things that a patient walks into an ophthalmologist for that potentially leads to death, this is actually one of the very few. And these tumors, again, arise from they're not skin tumors, but they're from the structures that live in the skin, the glands in particular. There are so many sebaceous glands in the eyelid and periocular region that it's actually surprising we don't see more of this. There's all these different named glands. Meibomian glands are the glands that empty at the edge of the eyelid and supply oil to the tear film. There's also glands of Zeiss. These are glands that are associated with hair follicles. But then all throughout the skin and the lining of the eye, this pink inner corner of the eye is loaded with some of these sebaceous glands and can harbor a sebaceous cell carcinoma. The problem with these tumors is these are known as the great masquerader. These actually look fairly benign or not very angry. They often look like just a little bit of a blepharitis or a sty. They're a little bit more common in the upper eyelid, probably owing to the increased number of glands we see on the upper eyelid. Makes sense. But these tumors classically are mistaken for a chalazion or sty. The styes and chalazion are plugged up oil glands. They're very similar to acne. They're kind of raised red, sometimes filled with whitish material. You kind of want to squeeze them and pop them, and they annoy patients who have them. I had one myself after taking care of thousands and thousands. I finally had one myself, and I finally had an idea what all these patients were talking about. They're very bothersome because you can feel it. Sometimes it gets into your peripheral vision. If you've ever had one, you'll know what I'm talking about. They're very nondescript in appearance, these sebaceous carcinoma. This just looks like a little gelatinous area at the edge of the eyelid. Could be any routine infection or mild blepharitis. And here's another one that was understandably called just a sty or a plugged up oil gland by the referring ophthalmologist. Another patient of ours that, again, just the doctor taking care of this patient previously just thought it was an area of a scar or sty that just was kind of not completely draining. Another example, you sometimes have to flip the eyelid. This is one that from the outside looks relatively okay. You might say that there's missing eyelashes, but when you flip the eyelid over, there's a lot of this lumpy, bumpy kind of cyst formation. And the classic history is that it's a chalazion or sty that's not going away with the usual treatments. Just for comparison, these are some chalazion tumor lesions. These are, again, plugged up oil glands. These are a dime. There's not a clinic that goes by that I work where I don't see at least one of these. It's just such a day-to-day occurrence because there's so many glands there, and they very commonly like to get dammed up. But these are just more classic chalazion. And again, the whole point of this is that these sebaceous cell carcinomas look exactly like this. They're the exact same pathology. Well, not the same pathology, but they're coming from the same structure. They're coming from those oil glands and just kind of filling up and growing. And in the case of a chalazion, it's more fluid or mucus material and surrounding swelling, but in sebaceous cell carcinoma, these are sort of cancer cells that are growing that look just like chalazion. And the other reason these are very difficult to treat is because they spread in a very unusual behavior. They tend to jump over areas. So even if you cut it out and you have the pathologist look at the edge and he says that you got it all, you might have missed it. There's another little satellite or island lesion just to the side. The reason we highlight these is because they're potentially lethal. You know, it's the classic textbook lethal condition in ophthalmology. And having practiced for about 15 years, I will say that probably over half of patients I deal with that probably had bad outcome, well, death. It was probably related to this. At least a third, I would say. And these are tumors, because they're so lethal, we do offer this radical surgery where we just have to disfigure patients and remove the whole eye and take out the eyelids and everything. The other type of cancer that you probably all are aware of is melanoma. Melanoma is a killer, as you know. It's a skin cancer. It's probably one of the more common sort of feared cancers out there because they're probably one of the most common. Fortunately, they're not that common on the eyelids for some reason. We see them from time to time, but it's like the sebaceous cell carcinoma. Thankfully, we don't have to deal with them too often. But melanomas, the same rules apply for any melanoma on the body. There's the ABCD rule. Asymmetry, sort of you can't fold it on itself. It sort of has an irregular scallop border. B is the borders. They are irregular. C is the color change. So they have different depths of pigment, different shades of brown or black in there even. And then diameter is the fourth thing. If it's bigger than 6 millimeters, it's much more suspicious. This is an example of the rare melanoma that occurred on an eyelid. And these tumors are scary also. These do spread. They jump into the bloodstream and show up in the liver is one of the most common places it goes. In these tumors, we very commonly sample the lymph node, the draining lymph nodes for this part of the face. It's usually the lymph node right in front of the ear, just to check to see if it's sort of spread. That is sort of one of the first stone to uncover, if you will, if we're dealing with a bad cancer around the eyelid. So to contrast, these are sort of benign lesions that are a dime a dozen. A lot of folks have these little benign nevi, and again, these don't quite follow the ABCD rule. They're small and they're well circumscribed. They're fairly symmetric. We see these little freckles all the time on the eyelid. These are nevi on the eyelid. Again, some pattern recognition here. You notice that the eyelid margin is relatively okay. The lashes haven't really dropped out over this tumor. You might say this one is a little bit irregular and the borders are hard to find, but other than that, fairly non-aggressive appearing. This is what's known as a kissing nevi. The upper eyelid is a little bit out of focus, but you can see that there's a corresponding growth on the upper eyelid. They think these are tumors that in utero or embryologically come from the same source, and as the eyelid divides, as the fetus develops, that explains why they're geometrically opposed and anatomically opposed to each other. Age spots, liver spots, these are sort of lentigo. These are benign things. Almost, you hit a certain age, you get some of these on your body. I have a few of these on my hand, and these are just related to sun exposure over the years. Again, flat, they're fairly well circumscribed, generally benign. Just another example of just sort of age or sunspots. So I'm going to skip over this Merkel cell because it's super rare, but this is a tumor that is just once every 10 years that somebody even specializes sees, so I'm just going to skip over it. But these are tumors that arise in a really weird neuroendocrine pattern. There's sort of nerves and sort of glands that the cells can go haywire and grow into these Merkel cell tumors. Just to contrast with something that they get confused for hemangiomas. These are just benign vascular tumors. But in general, the diagnosis is not something that anybody looking at your growth is going to be able to say definitively. The final diagnosis really relies on the pathologist, looking under a microscope, looking for characteristic features, really. The gold standard treatment is surgical still. I mean, most of these cancers can be treated if you properly remove them and resect them. The resection obviously requires rebuilding what you just took apart, and that's where I come in. or somebody who specializes in reconstructive surgery. Some of these patients do need some workup. We talked about sampling the lymph node, the first stone to uncover. Some patients do need imaging or CT scanning, MRI, PET scan, things like that. Usually these are for the more aggressive tumors, the sebaceous carcinoma and the melanoma. Again, basal cell carcinoma doesn't typically buy a patient a full body PET scan and a workup or a visit to the oncologist. There are other options for skin cancers of the eyelid or the face or any part of the body. Dermatologists very commonly freeze things off or burn them off. We typically don't do this on the eyelids, just owing to the precise architecture and the physiology and the needs here. We need the eyelid to work properly to blink and to cover the eyeball and distribute tears. So we typically don't like to burn or just freeze things off, because that in itself can cause problems for a patient. If you create a notch in the eyelid, if you create a scar on the arm, who cares? It just looks ugly, but a little scar on the eyelid can cause some real problems for a patient. Misdirected eyelashes sometimes can erode the cornea and lead into serious infections. Chemotherapy is typically not necessary for these eyelid or skin cancers, but there are sometimes local chemotherapies that we'll do. These include something called imiquimod. These are sort of chemicals that just destroy these tumors where they grow. And these do have a role for patients who can't have surgery. This is sort of a secondary option. Patient who can't have surgery, an example of this is a really debilitated patient who's on blood thinners, and that's probably the most common scenario we see, where the patient, if they stop their blood thinners, they're really at high risk of having a stroke or heart attack. So we really can't offer them surgery. And so in these cases, sometimes these local creams can help, but they're not really a great option for somebody a typical patient with a carcinoma. You've probably seen commercials and you've heard about, Jimmy Carter and all these. There's this whole new burgeoning field of immune therapy, activating the immune system to attack some of these tumors. Jimmy Carter was diagnosed with melanoma that was spread to his brain. This was probably 3-4 years ago now, and he's still going strong. He's quoted in CNN and things like that. So his brain's still intact, and I don't know. He's not my patient, but I'm pretty sure he was on one of these new immune checkpoint inhibitors. And again, the way these work is they sort of activate the immune system to target these cancer cells. And it's a really exciting area for not only skin cancers and melanomas, but all sorts of cancers. This is sort of the new approach to attack cancer. For basal cell carcinoma, there's something called a hedgehog inhibitor. Vismodegib is the term, but again, this works at the cellular level, trying to disrupt the growth of these tumors at the DNA level. But back to good old-fashioned surgery, we usually start with a biopsy. There's two different types of biopsy, two broad categories. One is incisional, one is excisional. In general, along the eyelid, again, because we worry about disrupting the normal architecture there, we usually do excisional. I usually try to take out the tumor, if it's small especially, and then put the eyelid together right away so that the patient can have comfort in a closing eyelid that covers the cornea. Again, if you're just sampling something on the arm, chest, or cheek even, you can certainly stab into it and just take a piece of it in any which way, and it's not going to cause a problem, except that it might bleed or ooze. On the eyelid, you leave a little chunk there where they close and there's a gap there. That overnight can evolve into a corneal ulcer or a serious problem. So we generally don't like little snip biopsies along the eyelid. Patients wonder why they need to, we need to put stitches in even. Well, and it's basically because we have to be a little bit more meticulous in this zone, just due to the importance of the eyelid for the health of the eye. But you can see different kind of biopsies shown here. On the right is called a wedge excision, where we just actually take a section of the eyelid out and put it back together, and that surprisingly does a very nice job. The wedge excision is one of the workhorses for the eyelid, because it not only gets out the tumor most of the time in one fell swoop, in one simple procedure, but it actually leaves the eyelid or returns the eyelid to its normal structure and function. You can see this picture where the bottom image is the post-operative appearance several months later. You can see there's really two things to point out. There's really minimal visible scar or anatomic disruption, but you see no notch, you see no patch of lashes missing. Everything is normal, so you can imagine that the patient's eyelid works and closes and the eye feels healthy. The same sort of procedure can be done on the lower eyelid. If this is a tumor right at the lash line that We can make a incision in the normal tension lines of the eyelid. So we open up, we kind of unroof it like opening up the hood of a car, and then we remove that section of the eyelid. Sorry if you're not used to looking at surgical photos, but this is my handiwork. That's right. So we bring the eyelid back together and re-drape it, so there's absolutely no scar at the end of this. Same thing for the upper eyelid. There's a technique where we just make an incision along the eyelash line, and you can see that we can remove the tumor and put the eyelid back together without any evidence that we were ever there. You probably heard of Mohs surgery. Mohs surgery is a specialty of dermatology. These are, to say simply, these are dermatologists who double as pathologists. They double as surgeon and pathologist. They cut the tumor out, and at the same setting, they'll look at it under a microscope in a separate room and just keep cutting as they go. It's equivalent to another type of monitoring, which is just intraoperative frozen sections. So I very often work with a Mohs surgeon. Well, they'll be responsible for taking the tumor out, and then they send the patient over with a hole in their eyelid that I'll then repair. There's another technique is where I take care, myself or a surgeon takes care of cutting out the tumor, but then sends the edges off to the pathologist. The pathologist then, while we're waiting for them during the surgery, looks at it under the microscope really quickly and tells us that the cancer is free of the edge of where we resected. They're the same concept. The whole idea is we just look as you go. It's not perfect because frozen sections are just sort of brief. They're like cliff notes. They give us a clue that there's no tumor there, but the pathologists say it's not the best sample because the way that they process it makes it prone for an occasional missed tumor. I've had them sometimes tell me on a couple occasions, they've told me that during surgery that the edge looked clear, and then they process the specimen the proper way later, put stains, and they show it later, and they find out, in fact, there was a tumor there. So that's a rare occurrence, but again, frozen is only so good. The proper way to process these takes a couple days. So that's why there's really no in between right now. It's either use the frozens or just get the specimen and have it checked properly by a pathologist. And that is an option, but with the eyelid, we sometimes have to leave the defect or the gap in the eyelid for several days. So this is a typical cancer of the eyelid that we send to the dermatologist, the Mohs surgeon, and they send it back with a big hole in the eyelid, and then we have to put it back together. Just another example of what they do. And the whole idea is they're just trying to spare as much normal tissue as possible. But it's a good technique, and we get good results. Sometimes these need a little further surgery to kind of get the eyelid to come together, but usually we can get good results. This is the same patient before and after. Several months later, you can see that the eyelid heals very, very well. Another example of a superficial basal cell carcinoma that the Mohs surgeon took out, and then we put it back together. So sometimes these tumors are sort of more complicated, and we need bigger flaps and grafts, and that's really where my specialty comes in, to kind of rebuild the eyelid and tissue around the eye. This is what's called a glabellar flap, where we make a V-shaped incision and pull that down to cover the defect. But you can see after they heal, they do quite well if it's treated properly. Here's a this is the same patient you probably saw earlier, but you can see how it's the tip of the iceberg sometimes. After the Mohs surgery, you can see that the cancer is in a much bigger area than one might have anticipated. In these types of surgeries, we sometimes have to do big flaps. This is what's called a Mostarde flap, where we kind of create a semicircular rotation. And it looks scary, but I'll show you what the end result is. It looks scary during the surgery, of course, but they can heal quite well. And you can see there's really very little evidence that anything ever happened. So again, this is just rotating the cheek and eyelid over to cover the hole. Another good example of how well. The one sort of drawback of having fair complexion and having that northern Scandinavian sort of the Northern European Scandinavian descent is you tend to get basal cell carcinoma, but the one thing about that type of skin, it heals very well, very commonly with no scars. So it's one of these sort of interesting trade-offs. Folks, Asian patients, Middle Eastern, pigment, anybody with pigment, African American, the skin tends to leave more scars and lumps and bumps and borders where the surgery was and evidence that we were there. But fair complexion usually heals quite beautifully. So just to summarize and conclude, skin cancer, especially eyelid cancer, is common, especially basal cell carcinoma. Probably, if not every day, every week I see somebody with a basal cell of the eyelid. A lot of it's pattern recognition. That's where the clinicians really need to know when they need to send somebody over to have a biopsy or to have something removed. Surgery remains probably the gold standard. There's other new things on the horizon. These immune therapies are probably the next big thing. And then these other sampling, we're checking for early spread is sort of another new area where we're going to be able to prolong life, actually, for some of these more aggressive tumors. So thank you so much for your time and coming to learn more about skin cancers. Hopefully none of you guys ever have to have anything major like we saw in this presentation, but appreciate your time. Oh, UV blocker, anything UV blocking is probably sufficient. It's the UV light that's the culprit. But sunblocks and hats, that's well known now. It actually wasn't that well known 10, 15 years ago. I would think they would. I think that's the whole point. I mean, in addition to just kind of making your eyes more comfortable, I think most good glasses have UV protection. But I wouldn't know. You could probably have them checked out. Yeah, I always see patients who, sadly, who even went to get things checked out, and then it's always the hindsight's 20/20. I have a young, not young, but 55-ish gentleman who had a tumor. This is just earlier last week that he actually asked his ophthalmologist to sample, and they did take it off, but never sent it off to the pathologist. And then something kind of grew back, and then next thing you know, he had a CT scan. I don't know what happened in between, but the patient was actively trying to get it checked out and was sort of brushed off. And again, these are sort of these hindsight horror stories, but long story short is he had a tumor all invading deeper in the eye socket. He's one of these patients that may have to lose the eye. And so it's always, what if, and we don't know whether if the day one when he presented with it was already deep in there. It's just unknown, but I think that's what's important about you guys all coming to the lectures like this, to know yourself. Sometimes, doctors are fallible also. We can only use our best clinical judgment, and as long as everybody in the room, when you're at the doctor, is on the same page and has the certain level of suspicion and education, I think it really helps. Yeah, we're looking for those things. Exactly with this presentation, those characteristics are the things that are going to prompt myself or somebody who knows what they're doing to either worry about it or not. Some of these, I never tell anybody that, oh, this is 100%, you don't ever need to do this. If there's anything about it that brought them in, I'll tell them it's most likely X, Y, or Z. Here are the parameters that we might remove it later. And some of them have nothing to do with cancer. They just have to do with if they get big enough or they bother you, or if it gets ugly or you don't like it. That's another reason where we could possibly take it off. And I generally always give folks the option to have some of these things removed. Now the insurance company has to have certain parameters for covering removal, because everybody has a little growth or skin tag or something somewhere. In general, if it's not a suspicious growth, it either has to cause some sort of irritation, has to be getting larger. Sometimes around the eye, if it's blocking some peripheral field or you're just seeing it in your side vision, those are sort of the reasons that the insurance third-party payer might justify it. Don't like the way it looks is not typically a good one for the insurance. Yeah. Yeah, that's actually, there's a lot of different theories. There's several, including hormonal actually. There's a certain set of patients they think there's some hormonal imbalance in the bloodstream. I actually don't know. Patients always ask me what causes these styes, and I don't have a good explanation. And it's really not anything to do with hygiene necessarily. That's one of the common myths, that you're not cleaning your eyes or you're not taking care of your and that's not completely true, because I see patients who are very meticulous about cleaning or washing their face, and they still get them. There's some inherent predisposition for these things. The strongest risk factor is if you've ever had one before, not surprisingly. So anybody who gets one, I tell them, you're at a much greater probability than anybody else out there to come back to have to deal with one of these on the same eyelid or a different eyelid. Yeah, any growth so some of these growths look really just like inflammation or an infection. And again, the tip-off is that it didn't get better with the usual course of treatments. Generally, the magic rule is a couple months. Most of these infections and inflammations are gonna resolve within a few months. 6 months is sort of the long one. If it's beyond 6 months, I would certainly, at that point, recommend biopsy, or at least start thinking about a different diagnosis. Yeah, different doctor. I hate to say, again, I only see the horror. I see the most complex ones that are referred by other doctors who, somebody else missed something, and so I have a disproportionate sample of examples. But for the most part, most people trained in oculoplastic surgery, dermatology, even ophthalmology, should be, in their core training, have a basic understanding of the parameters that make something worrisome or not. So both share a lot of similar features as part of their appearance, behaviors, and the treatments. So especially when they're small, I have no problem with the dermatologist freezing them off. The one thing I don't like is we never had a diagnosis. So those little red things you get frozen off, it could have been a squamous cell carcinoma. The only good thing is that it's an appropriate treatment also. Sometimes that freezing or burning actually kills it off completely. And again, when they're very small, it doesn't matter that it was squamous cell versus a AK. Either way, it's gone. So that's a good way to look at that.
But what about using a cream on it?
Well, those chemotherapy creams, I'll have to say, they're very expensive. So some insurances won't even cover them. And again, they're really, because we don't have a good diagnosis, we never know we got it all completely. I don't think they have much of a role as opposed to surgery. I think surgery is still probably the better option. The one other thing I'll say about use of those creams around the eyelid, the imiquimod, which is the most common, it's Aldera is the trade name. You've probably heard of this. It's very irritating to the eye. So patients who have to use that, their cornea burns like crazy. So that's another. Yeah, I think it's a very common treatment that the dermatologists use. I don't use it very often because I'm usually dealing with tumors around the eyelid. Right, they're the same, whether they're benign or malignant, the treatment would be the same. So those creams and freezing, again, would work. But that's one of the inherent problems. We never know what we were dealing with. So I think that's the one benefit of surgery also. We can always have a sample, and yeah. Absolutely. I don't have any strong, I think SPF is the only known the only known thing that I don't have a particular recommendation. I think the dermatologists like SPF greater than 30. The eyes are particularly, a lot of people are sensitive to a lot of different creams. The other new sort of thing, and my wife is big into this because we have little kids, she's worried about all the chemicals that are in there. So there's this burgeoning field of new skincare products and skin cancers. Who knows that some of these products that are in there we're going to find out 20 years from now that these were causing other types of cancers. The saga continues. But I think the general take is just avoid sun as much as possible. So if you're going to be out in the sun, hats and sunblock. I don't know that there's any particular brand or formulation. If you want to go by the general rules of where the skin cancer grows, it's less common on the upper eyelid because the brow and the forehead blocks the sun there a little bit on its own. The lower lid and the inside corner are probably more susceptible. So that's a good way to think of it also. Yeah, they're not formulated to go into the eye, but there's a lot of them out there that are actually they sort of compensate for. They know it's going to drip into your eye, and they're better than others. I don't have any specific recommendations. I've learned over the years that if just playing sports, and the stick ones tend to work better for me because they don't tend to drip and mix with the sweat and drip into my corneas. So. Oh, restasis? It has a role. We see a lot of patients on that. It's an cyclosporin is the active ingredient. It's a very, very mild form of, cyclosporin is a chemotherapy agent. And it really, what, excuse me?
Does it work?
It works in some patients if patients have an inflammatory dry eye. There's sort of 100 different types of dry eye out there. So patients who have a lot of inflammation, we found that works reasonably okay. The base in there is also is the same as Refresh that you can get over the counter. So some people actually don't even need the restasis. It's otherwise the same. So I always tell patients just to try that first because it's very similar. Besides, there's no active cyclosporin in there. All the time. Yeah, I used to actually go to their facility and they'd do the surgery and I would immediately do the reconstruction, but it just wasn't efficient and practical. So now what they'll do, they're over in Gottschalk, and some of the doctors in the community will just coordinate the day. So the patient will go to the dermatologist's office, have their tumor resected, and the dermatologist will try to be done at a targeted time, and then we'll have them on our schedule downstairs in the operating room or a different procedure room. So it works out usually. We usually do it within if not the same day, the very next day. And if there's a big gap in the eyelid, we do some things to protect the cornea in between, sometimes a contact lens or slathering with ointment just for a night. And most of the good ones are pretty good about it. They don't put a suture in there just to protect to pull the remnant or the remaining eyelid down over the cornea, just to bias 12 to 24 hours before we could do the reconstruction. Good question, though. There's a lot of debate. I mean, it's costly actually from a large macroscopic healthcare perspective to have two specialists, and so there's some debate of whether is it the best thing, is it sustainable, but it's a good option because and theoretically, or one theory is that if you have one person focusing on removing a tumor, somebody completely not worried about the resection that's just solely dedicated to the reconstruction, you might have a better result. That's debatable, but I do buy into that a little bit because in my mind, when I see a cancer, I'm already starting to think about which types of flaps and which direction I want to pull things. And so if you're solely there just to get rid of that darn thing, and you're not caring about the flaps afterwards, you might do a little bit better job of getting rid of it. There's no scientific evidence that that's right or wrong, but there's just one reasonable theory. Absolutely, that's a great question. So flaps and grafts are very common. In general, we try to use flaps because they're less maintenance and they have their own blood supply, and we don't have to worry about mismatches and things like that. But we very, very commonly don't have a choice. So screen grafts are very common. And thank you again for coming. Really appreciate it.